Good morning or good afternoon. I can see that the list of attendees is still growing, but it is now 5 past the hour. So I'm just going to make a start and start introducing everyone. So I wanted to welcome you all to this webinar, Cost Effectiveness Thresholds and Decision-Making in Healthcare, which kicks off a special series that the Health Intervention and Technology Assessment Program, HITAP in Thailand, are co-hosting with the Center for Health Economics at the University of York. So I'm Jessica Ochalek from the Center for Health Economics, and I'm going to be your chair today. So I'm delighted to welcome you all to this kickoff webinar. Our aim here is to provide an overview of the state of the field of health economics and to touch on hot topics in the estimation and application of cost effectiveness thresholds. So we have today with us experts in the field who are going to give us a flavor of some of the important research that's currently happening around cost effectiveness thresholds and an opportunity for you to ask questions. So before I introduce our speakers, I would like to go through a bit of housekeeping. So as you can see on the screen, this webinar will be recorded in order to prepare summaries. Please mute your microphones unless you're speaking. You may use the chat function to send questions or your remarks at any time. And please use the raise hand function to show an interest to speak. So we're going to save all of the questions until the end of all of the presentations. However, if you have any questions, especially points for clarification that come up while people are speaking, please feel free to put those in the chat function, and then we'll get to those when we get to the Q&A section. So now that that's out of the way, let me introduce our speakers and the agenda for the day. So we have with us Dr. Laura Vallejo-Torres, who is an associate professor at the University of Las Palmas de Gran Canaria in Spain. We also have with us Dr. Shankar Prinja, who is professor of health economics at PGI Chandigarh in India. Dr. Wanrudee Isaranuwatchai is program leader and director at HITAP in Thailand. She is also an affiliated scientist at St. Michael's Hospital and an associate professor at the Institute of Health Policy Management and Evaluation at the University of Toronto in Canada. Our discussant today is Dr. Nancy Devlin, and she's professor of health economics at the University of Melbourne in Australia. I'm very excited to have this excellent group of experts here with us, and I hope that you all find the session enriching. So each of our experts will speak for 10 minutes, and then Dr. Nancy will give the discussion, and then we'll move on to the Q&A session. So we may begin with Dr. Laura's presentation, please.
Hi, everyone. I'm moving now to share my screen. There you go. Great. Can you all see my screen now? Hi?
Not yet.
Can you all see my screen?
Not yet.
Let's see. So let's see. What about now?
Yes, we can now.
Yes, perfect. Well, thank you very much. I had such a huge problem trying to connect, so I was a bit late joining the meeting, and so I really want to apologize for this. And now, well, just want to first thank the organizers for inviting me. It's really a pleasure for me to be here and to discuss about these topics, which they're very close to my heart because this is what I've been doing for the last few years of my research career. So I'm really happy to be here and discuss about this. So the aim of this talk, I'm going to try to present what we summarized in this paper, which was published in 2016 in Value in Health. In this paper, what we tried was to answer 3 questions. So one question was, what were the reasons for using and not using a cost-effectiveness threshold? What should this cost-effectiveness threshold reflect? And also, how can the cost-effectiveness threshold be empirically estimated? So to provide some context to this project, or to this first step for us in analyzing this area, we were working, so me and the co-authors of the paper, at the Health Technology Assessment Unit in the Canary Islands in Spain. And we were asked by the Ministry of Health to develop some research on how we could estimate a cost-effectiveness threshold for the Spanish system. So moving then to the questions of why, how, and what. So why, what, and how. So starting with why. So why do we need a cost-effectiveness threshold? Well, the answer is very simple, really, is to identify interventions that are cost-effective. The problem here, the usual problem that we face when we are analyzing a technology, is that in most cases, what happens is that new interventions are more costly, so they are more expensive than existing ones, but they provide better health outcomes. And we need to establish whether that intervention, the cost of those interventions, represent a good value for money. So I'm sure you are all familiar with this, but just allow me to very briefly talk you through this. So we make sure that, for the rest of the presentation, we follow the same terminology. So in cost-effectiveness analysis, what we normally do is to come up with a result measured in terms of the incremental cost-effectiveness ratio. So we compare the incremental cost of the new technology versus an old or standard technology, and the effect in terms of, for instance, quality-adjusted life years. So at the end, what we get is what is the incremental cost per unit of effectiveness gain. And as an example, imagine that we are evaluating a new drug, and we come up with a figure such as this new drug is able to provide better health outcome, but it's also more expensive. And the incremental cost per quality, so per quality-adjusted life year of this new drug compared to existing therapies, is $30,000 per quality. So the question is this cost-effective? Well, with this information alone, we cannot really give an answer to that question. So what we found in that review was that, well, not everyone agrees with having a threshold to make these decisions. So here I will provide some arguments for and against this. So in terms of the arguments for not using a cost-effectiveness threshold, well, first there is a criticism which is really more general to the cost per quality approach, which is this idea that the assumptions behind the use of economic evaluation or the cost per quality approach are really not met. And one of them is this idea of the perfect visibility of the healthcare program. But as I said, this is a criticism general for the whole cost per quality approach. But if we move to criticisms which are more specifically concentrated on the use of the threshold, what we find more often is this idea that people think that if we take this approach and we have a threshold, and according to this threshold, we say whether interventions are or not cost effective, and then we just basically incorporate in the healthcare system all the interventions that have a cost per quality below this threshold, then we will lose control of the budget, because basically if we have to include everything that is cost effective, we will not be able to say how much we are capable or willing to spend on health. And another criticism to the use of the cost per quality threshold is this idea that if the rules are there, so if everyone knows the rules of the game and manufacturers knows how much a healthcare system is willing and able to pay per unit of effectiveness, they will always price the new technology up to the point where the cost per quality is equal to this cost effectiveness threshold. So basically, it's sort of transferring the full value of the technology to the manufacturers. Well, in terms of the arguments in favor of using this threshold, is this idea that, well, exactly like we do for cost effectiveness analysis, cost per quality estimates, this is an approximation, and we think it's a useful approximation to improve efficiency. There are ways that have been proposed to address these arguments against the use of the threshold, such as the uncontrolled increases in the budget. Well, this can be managed if we also take into account budget impact analysis to make decisions. And also this idea that the threshold doesn't need to be a fixed value that is not changed over time, although some systems do have the same threshold for a couple of decades now. But the threshold can be adjusted to take into account changes in the efficiency and the budget over time. And also, there has been a number of arguments which go beyond the argument of efficiency, more specifically, arguments that basically want to take into account that if we have this threshold, if we have this rule, decision-making will be more consistent and more transparent, and there will be less room for decision makers to be arbitrary. So I now move to the second question about what should the cost-effectiveness threshold reflect? So here I go back to the main question of why we do cost-effectiveness analysis. So normally what we want to answer is the question of whether the health benefits or the benefit associated with the health intervention are larger than the associated cost. But we have a problem here, which is that we measure benefits normally in terms of health, because it's what we want to maximize, but we measure the cost in terms of monetary terms. So we measure it in terms of the money. So we cannot really compare these two. We have one dimension measured in health units and the other dimension measured in monetary terms. So, and when we arrive at the cost-effectiveness ratio, at the incremental cost-effectiveness ratio, and we compare this with the threshold, really what we are doing is translating one of these two dimensions into the other one. And I talk you through this in more detail now. So one idea is that if we have benefits measuring health and cost measuring money in monetary terms, then one thing we could do is to translate the health units into monetary terms. So basically assigning a monetary value to health gains. And this is normally denoted by the letter V. And this is a way, well, it basically provides a way of applying a monetary value to health gains. So if we do that, we simply multiply the monetary value of health by the health gains of the technology, and now we can compare them because we have a measure of benefit in terms of money and a measure of the cost also in monetary terms. And therefore, this threshold should be measured in terms of the monetary value of health gains. But there is an alternative of applying a monetary value to the health gains is to translate the cost of the intervention into how much health we could have gained if we had applied that money in another alternative. So therefore, this is what we call the opportunity cost. So imagine that we measure this, and this is normally denoted by the letter K. Then we can compare the health benefit of the intervention with how much health we will get if we spend the amount of money that is required to fund this new technology on alternative uses. And this is therefore when we use the cost-effectiveness threshold as a representation of the opportunity cost in terms of health. So what are the arguments against and in favor of these two perspectives? So I'm going to call the monetary value approach the demand approach, because this is how it's normally termed in the literature, and the cost and the opportunity cost approach, the supply approach. So in terms of the demand or the monetary value, well, the advocates of this approach, they highlight how this approach basically allows the threshold to reflect the societal values of health gains. And this takes into account the preferences of the society, which are the ultimate people affected by these decisions, really. It allows comparing the societal gains with the societal costs associated with the new technology. And it has been pointed out that this approach is more relevant, is more appropriate when we live in a context where we have some flexibility in the budget. So this means that in order to fund a new technology, you don't necessarily have to stop doing something within your healthcare system, but you can have a new budget to fund this. So this new budget obviously is competing with other public sectors. So there will be opportunity costs, but they will fall outside the health budget. For the advocate of the supply side approach, what they argue is that the threshold should reflect the opportunity cost in terms of health. So if we have to disinvest on something within our healthcare system, we have to measure how much we're going to lose in terms of health in this society and compare with the health gain. This takes into account...
I'm so sorry to interrupt you. So you've had 10 minutes. I'm going to have to ask you to wrap up, even though there's a lot more you could say. I'm so sorry.
Yes, sure. I can finish with this and then we can leave the rest if there are some questions. So it takes into account the budget and also allows the comparison of the health gains and the health losses from displaced resources. And this is more appropriate when we have a fixed budget. So therefore, when we have these opportunity costs falling on the healthcare budget. So to finish, how this has been measured. So I finished the last of the 3 questions, and I will do this in like 1 minute. This has been estimated in the literature using different approaches, how to empirically measure this. For the demand approach, we found willingness to pay studies is the most often methodology to measure the monetary value of health, and also measure using the value of a statistical life, but less often. For the supply side, we found 2 different ways of doing that. One, which is not really empirical, but is sort of observational. So it's looking at the decision that has been made and what was the underlying value for the intervention there. And then, which is the one that is being done more and more often in many countries, is trying to measure empirically how much health is lost when we remove spending from the budget. So trying to measure this opportunity cost in terms of empirically. And I think I've stopped here, and we can move, and we can take the rest later on if it's required. Yeah.
Thank you so much, Dr. Laura. That was absolutely fantastic, and you covered quite a lot of ground there. So
yes.
We've already had some questions come in, so we're going to save those for the Q&A, and we'll move directly on to Dr. Shankar's presentation.
Thanks, Jessica. I'll share my screen and just confirm to me if you can see my slides in full view.
Yes, we can see them. Thank you.
All right. Thank you very much. So I think Dr. Laura has set the stage in a very beautiful manner, and it allows me a very good platform to now take a much more deeper dive into one of the methodologies that we tried to apply in Indian context, and to show you how potentially it could influence the policy and what are the different ways in which we are trying to envision that this cost effectiveness threshold could be applied for policy use. So just to begin from where Laura has left, and to say that there are these 2 approaches between the demand and the supply side. And we particularly chose the demand side approach towards valuation of a cost effectiveness threshold in India. The principal reason why we chose this particular approach was more related to the context in which we are trying to measure the cost effectiveness threshold. And we were trying to relate it to the overall, the achievement in terms of universal health coverage that we've been able to do in the context of India. So we feel that, and the argument within the group was that if you're really at that level where you've saturated the coverage of healthcare services, and most of the people who are entitled to certain services, they're been able to get quality healthcare services, then potentially a supply side approach towards valuing the marginal gains in terms of losing health by disinvestment or gaining health by additional investment would be a good approach. However, we felt that a more aspirational approach, which reflects on the societal preferences, at a stage where we are almost like halfway through, where the glass is like half full, was probably more appropriate. And the other reason we felt was that given the varying shares of private and public sector provisioning of various healthcare services, and given the fact that the efficiency of these 2 are going to be very different, so those estimates of the marginal productivity of these of the public and private sector spending may not necessarily be the same, and so we felt that a demand side approach would be more appropriate. And in order to estimate this threshold, we basically undertook a nationally representative survey, which was commissioned by the HTAIN, which is the formal agency for HTA in India. And we carried out a large household survey, which was undertaken in 5 states, chosen in a manner that represented a distribution in terms of income, the health status, and the geographical location. And we had a total of nearly 5,500 respondents who were interviewed on 12 hypothetical conditions. And the overall number of observations in the data that we had was slightly more than 21,000. So based on this large survey that was carried out house to house, in which face-to-face interviews were carried out, we basically in each of these interview, we first assessed the amount of health that is perceived to have been gained in each of these hypothetical health conditions if you were to become normal, and the time trade-off experiments were carried out. And then subsequently, the willingness to pay in order to be healthy was elicited from each of these individuals who were given these hypothetical scenarios. And then together, this information was combined in a variety of statistical methods to compute the willingness to pay per quality adjusted life year gain. So that was just to summarize the approach that was undertaken. And we had a variety of potential choices to make in terms of analysis. And finally, what we chose is what is represented on this slide. So we used an aggregated approach towards estimating this willingness to pay per quality gain. We not only did a pooled estimate, but we also estimated state-specific and health condition-specific estimates of WTP per quality, and the estimates eventually were weighted according to the region, the area, the gender, age group, and education. And this was done to make sure that any subsequent sampling distributional imbalance from the population estimate was taken care of. So overall, what we found was that in a range of these 12 conditions, which were nothing but 6 different conditions, but with 2 levels of severity, we found that the estimate of willingness to pay per quality varied from nearly about 150,000 to close to about 300,000 Indian rupees per quality gain. And on an average, this value was between 200,000 to 300,000, depending on the method of aggregation that you chose, the mean estimate that the statistical approach that you chose. But we particularly used this aggregated approach in order to measure the WTP per quality. And eventually, we applied a series of different weights in order to generate a representative estimate of the willingness to pay per quality, which eventually, after adjustment at the national level, came to around 132,000 per quality gain. And you can see that there are substantial differences across different states, which arise as a result of various population level characteristics that are different in these different states. And if I try and put it in perspective of the overall where we stand in terms of the per capita GDP, which tends to be one of the most referred benchmark against which we plot the threshold, then the estimate that we derived was close to about 0.8 of the per capita GDP. So this is where we are in terms of the purchasing power parity, and majority of the countries, as we see, lie anywhere between 0.5 to 1.5 of per capita GDP. Now, moving on to the next part, which is how do we feel that this is something that could be potentially used? Now, just to put in context, it's not the only estimate of a threshold that we derive from Indian context. There are several other attempts towards measuring a supply side estimate of the threshold, which have been done by colleagues from the York University, as well as more recently an estimate that was generated by colleagues from the University of Argentina and the colleagues from IDSI, majority of which come up with an estimate of threshold which is much lower than what we reported. So ours was 0.8, but here the value ranges from nearly about 8% to about nearly 24% of the GDP, which is fairly lower than what we report, which is close to about 80% of the per capita GDP. So what do we do with this? So we have very varying estimates. What we reconcile is that between these two estimates, perhaps what we can definitely infer is that any intervention that falls below the estimate of the supply side threshold is something that we definitely need to fund, even if the question is around displacement of healthcare funds within a constrained budget. Whereas if we are looking at an intervention which falls where the ISER falls above the demand side threshold, but below the supply side threshold, which is above the supply side threshold, but below the demand side threshold, then what it means is that it is an intervention that definitely should ideally be viewed in terms of additional investments. So we wanted to be a little more aspirational given the level at which we were in terms of achievement of UHC. So we definitely feel that this is a range where we can be, which we consider as something which could be used for making these decisions about cost effectiveness. Moreover, in a federal structure like the one that we operate in India, where there is a sharing of budgets between the central and the state governments, we also feel that there is also a merit in terms of using the cost effectiveness threshold as a mechanism for a more equitable public financing, where some degree of risk adjustment could be introduced. And what do I mean by that is that let's assume a situation where the value of a cost effectiveness ratio for an intervention is less than the state's cost effectiveness threshold. So if we determine state-wise these thresholds, then entirely the budgetary implication should be on the state. But if it is something that falls above the state threshold, but is less than the national threshold, then potentially there could be some degree of cross-subsidization that could be done by the central government, either in entirely, or there could be some kind of a funding arrangement, which is on a sharing basis. So this would eventually mean that the richer states could potentially be cross-subsidizing some of the interventions that are being made available to the states that have relatively lower levels of income and hence a lower threshold. There are also other aspects to the application of threshold that we are still in the process of exploring. The first is that there's been an argument within the stakeholders that even the threshold could be broken down based on the income levels of the population and or characteristics of the population. And then maybe it could be that a different public financing scheme, which is catering a given set of population with given characteristics, there could be a threshold that could be specifically set for that scheme. However, there are concerns that this could rather be more detrimental from an equity lens, because then a scheme, public financing scheme, which is specifically for the poor, will eventually become poorer because you have set a lower threshold. So as a result, what we feel is that while that may not be necessarily appropriate, however, if in certain cases there is an argument to be more aspirational in terms of budget allocations, then definitely a willingness to pay QALY that is representative of more wealthier strata of the population could potentially be used. The other argument is that there could be disease-specific or severity-specific thresholds where there could be some flexibility for offering high-cost treatments, let's say, in certain contexts like cancer or certain other conditions. So that's a work in progress that we're still trying to identify if there are some modifiers or price weights to that. And then
Dr.
finally,
Shankar, sorry to interrupt you. I'm going to have to ask you to wrap up at this point, please.
Sure. This is my last one. And so there's also going to be a requirement for potentially periodically revising this threshold with changes in levels of income or changes in the characteristics of the population for that matter. And given the data that we have, which is quite disaggregated, and we have population level characteristics, we feel that there could be a formula that could be created that could potentially be used in future for periodic revision of this threshold value. But nonetheless, cost effectiveness is still going to be one of the criteria that would be eventually used for decision making. And thank you very much. And there's been a lot of good contribution from several other organizations that have been part of this study. Thank you very much.
Thank you very much, Dr. Shankar. Again, we've had some questions, so I'll save those for the Q&A at the end, and we'll now move on to Dr. Wanrudee's presentation, please.
Hi, thank you, Jessica. You can hear me okay?
Yes, we can.
Okay, and I'm going to hope that you can see my slide now too.
Yep, we can see your slides.
But not in the... Yep, this good?
Yes, perfect.
All right. So, is higher better? That may be the question we want to think about it now. So if I can ask Francis at HITAP, can you launch the poll, CET1? And I'm hoping it will come up. So if everybody can help share your thoughts. Do you think higher cost effectiveness thresholds better? Oh, we have a lot of people. Nobody said no. Oh, no, actually a couple now. I shouldn't say that. So this is great. We talk about Dr. Laura was talking about why we should estimate threshold. We have really interesting case from India. So I'm going to take you a step further, because when talking about cost effectiveness threshold, I believe you know that a lot of people keep saying that we should increase it, right? And I'm very, very happy to say that we actually will not answer this question. We won't say whether should we increase it, but the question that you'll be looking at is going to be something about that. But it's really interesting. So I'm not sure everybody see the result. Can you share the result so everybody can see, Francis? Thank you. Yeah, so it seems a lot of people are thinking. That's a good thing you're thinking about it. You're in the right place. Some people say yes, okay. A bit more people say no. So we kind of get like a distribution. So thank you, Francis. So my name is Wanrudee, and this work that you're about to hear in about 8 minutes left. Certainly, I didn't do it alone. It's certainly with the team at HITAP, the Thai FDA, Hitotsubashi University, and National University of Singapore. So yes, as we already hear that economic evidence has been used to support policy making process. We have been doing that too in Thailand since 2008. We all know what ISA is, and we know that for something to be cost effective, ISA has to be less than CET, or cost effectiveness threshold. That made the threshold a very important item. So if we were to have like a role model, it really could be Spider-Man, who once said, or Uncle Ben of Spider-Man, who once said, with great power come great responsibility. Because to us, health economists or researchers, you pretty much can make anything cost effective, right? By working with 3 things. And one of the things is to increase the threshold. If your threshold keep going up, it could be that you can make more things cost effective. And there have been a lot of requests talking about, should we increase the threshold? So in Thailand, we also receive that question a lot. And Thailand, though, has a unique case because similar to UK, we have an explicit threshold stated, but we also have increased it twice in 13 years. So the first time we used it, it was set at 100,000 baht, so around 2,800 US dollar. We increased it to 120,000 baht in 2010, and in 2013, it was set at 160,000 baht, so around 4,500 US dollar per QALY. Okay, and it's been like that for 10 years. So you can imagine a lot of people asking, should we increase it? But before we answer whether we should increase it or not, our team actually would like to learn from what actually happened if we were to increase it. So that was our question. We set out to look at when we increase the threshold, what actually happened? What happened to the drug price submitted by the manufacturer? And what happened to the chance that the high cost drugs will be included? So we're not going to say, should we increase it, but we're going to look at what happened when we increase it. Thailand is an upper middle income country. Besides thinking about threshold and other statistics, I thought I put some nice picture of Thailand for everyone to also remember Thailand by. So Thailand also has, it's covered, we have universal health coverage, and the main public health insurance is the universal coverage scheme. It covers 80% of the people, and that is the group, the data set that we'll use, okay? So we're not using data from the other 2 schemes. So it's the majority of people, but it's not the entire Thailand. So we did a retrospective secondary data analysis. We look at all economic evaluation reports from 2008 to 2020. And we only include reports that were reviewed by the subcommittee. We held several stakeholder meetings to comment and on our proposed plan, and we also published our protocol as well. So our goal is to look at when we increase the threshold, did it affect or influence the submitted drug price or the reimbursement decision at all? But we know there are a lot of other factors, and we list those, and we got those from literature review. We adjusted for variable, like is a drug for rare disease or not? Is it first line therapy or not? Is it a chemical versus biologic drugs, things like that. But we know we're still prone to unknown confounder or among other confounder that we don't have data on as well. And we use a different approach by separating observation into two groups. The control group are the drugs that have very high ICER, so greater than 300,000 baht. So even though we increase the threshold, we don't think it's going to make any difference to this group, right? So then the other group, the intervention, is when we know that if we increase the threshold, this group may be affected or influenced. So, and we assume that the impact of other factors between the two groups are the same. And the difference between effect 1 and effect 0 over time, that becomes the impact of CET. So I'll elaborate. The total number of observations, we in total include 55 reports that include 201 drugs. And in total, we have 295 observations. Yes, the number keep going up. And it's because one report sometimes include more than one drug. And one drug often can be used for more than one indication and one target population. So in the end, the total sample size is 295. So what did we find? When looking whether an increasing threshold affect submitted drug price by manufacturer, we found that in the control group and the intervention group, you can see that the trend is the drug price actually is dropping. But if you were to look without increasing threshold, the drug price it should be here. So in other words, the drug price dropped a little bit less for the intervention group. Okay, so the potential effect of CET would be the difference between these two. And we found that, as mentioned, compared to when CET was at 100,000 or 120,000, the yearly drug price for when CET is 160,000 appear to be higher. So it dropped less. Okay, but it's not significant. That's what we found. So how about if we look at the chance that a drug would be included in the national list of essential medicine? We found that, if you look, we see similar trend, right? The chance that drug will be included, it actually increased. But again, without increasing threshold, the chance that of being included in the national list of essential medicine should be here. So this is the potential impact of increasing threshold. So we found that the drug submitted when CET was higher appear to have higher chance, so 1.6 times more likely to be included. But again, it's not significant. So what did we conclude? We conclude that there's no evidence to support that increasing CET influence submitted drug price and reimbursement decision at the moment. So increasing threshold again right now, we don't have evidence to support, but there are lots of limitations. This is the first and only data set so far to exploring the impact of increasing threshold to our knowledge. Regression result in many ways is somewhat more exploratory rather than definitive. There could be a lot of other potential confounder that we have not adjusted for. There also there's some data limitation. The drug price that we are talking about is actually not the final price, so it's before price negotiation for those that went through price negotiation. So what we are building on from this work, and I'm wrapping up now, Jessica, just one more part, is that we have made a request to the policymaker to help us continue collect data so we can update the process over time. And to inform the policy better, we now are studying a qualitative study to actually help us better understand what this number is telling us. Now to end, just one final thing, Jessica, please. Francis, can you launch CET2 poll, please? So after you hear all this, that there's no evidence to support, should Thailand increase our cost effectiveness threshold after 10 years or no? Okay, oh yes, no. There's still a lot of people thinking it's good because we may need more data. Wow, but the answer is quite close. Okay, oh wow. So there's a lot of people still thinking, so the answer is coming in. So maybe I'm gonna count 5, 4, 3, 2, 1, and maybe Francis, can you share the result so everybody can see it? Wow, so we still get some people say yes, some people say no, a lot of people still thinking. So I'm hoping that Nancy and Jessica will tell us the answer before the end of this webinar. So thank you very much, everyone.
Thank you very much, Dr. Wanrudee. I think we have quite a lot to discuss now in the Q&A, so you've set us up well for that. So I'm going to pass over now to Dr. Nancy for our discussion.
Thanks. Thanks, Jessica. And can I check first of all that everyone can hear me okay?
Yes, we can.
Terrific. Thanks very much. Well,
Thank you.
I'd like to begin just by saying really well done to Lara. Sorry, can you hear me okay?
Your slideshow is on sort of presenter view mode, I think.
Oh, yes.
There we go. Perfect.
Lovely.
Thank you.
Thank you. Yeah, I just wanted to begin by saying well done to Lara for providing such a wonderful overview and introduction to these presentations, and also to Shankar and Wanrudee for sharing the work that they've done. And to me, that really highlighted what I wanted to say in my first slide here, which is what an amazing amount of progress has been made in this research field. I first became interested in cost effectiveness thresholds back in 1999 when NICE was established, and it was not long after that that I arrived in the UK and was really interested in following the way that health technology appraisal would be done. And in 2002, there was a Health Select Committee inquiry to look at the initial decision making that was done by NICE, and there was a lot of really interesting things that came up at that sort of early point of review. The first thing is that it was quite clear by that stage, a few years into NICE's development, that they needed a threshold. You know, you can't assess cost effectiveness evidence and make a judgment as to whether any individual technology represents good value for money without having something to compare it to. So you need to be able to draw that line in the sand. And by a few years into NICE's establishment, it became clear that this threshold range of £20,000 to £30,000 per QALY gained had emerged. And it had kind of emerged mysteriously from committee deliberations. But what was also fascinating, and this is kind of the point I wanted to make about how far we've come in this whole field, at that point, NICE was formally maintaining that the Institute does not have such a threshold, and it appeared to be very controversial to even say out loud that you needed a cost effectiveness threshold and that you were using one to judge ICES. But it was quite apparent even then, and certain in the work that we did and was published in 2004 about NICE's cost effectiveness threshold, and in subsequent work that we did led by Helen Dakin, it was really clear that ICES clearly were being used, and that some sort of threshold was being used to determine, you know, whether or not an ICE fell within an acceptable range, because you could use the ICEs to correctly predict over 80% of the decisions made by NICE. So it was clear that a threshold of some kind was being used. But what was unclear is exactly how it was being used and what the role of other factors other than cost effectiveness were, what those other factors were, and what role they had on decisions. So I think it's really encouraging that in the nearly 2 decades since we did that initial empirical exploration of NICE's decision-making, that we now have new methods available to estimate the supply-side opportunity costs, and a really quite strong body of international evidence around that, included that being presented by the speakers today. And we also have a lot more evidence on willingness to pay as well, and a better understanding of the relationship between these two things. And as I thought came out very nicely in Shankar's presentation, what the relationship might be between these two types of evidence. So I think the field has come along really nicely. Next slide. But I do think there are some really interesting remaining questions. And I think there's also, by the way, some really good questions in the chat, the Q&A being asked by participants as well, which we'll get onto. So one of the questions for me, and this is partly, I think, what Wanrudee was sort of getting at in her questions for the audience as well, is, so we've got some good estimates of the opportunity cost now, but given that that evidence is based upon sort of average estimates of the relationship between the budget that's available and the achievement of outcomes at the system level, how often should we adjust, let's break this down into two parts. How often should we re-estimate the supply side threshold? And if we reveal that the value of K is changing through time, then how often should that be implemented in a different decision rule? Because over time, clearly there are going to be changes in all aspects of the things which make up those estimates of K. So budgets change, both in nominal and in real terms. The underlying technical efficiency of the healthcare system is changing. The underlying epidemiology into which healthcare is provided is changing. And all of these things will affect estimates of the supply side threshold. And then the second point is, what are the implications of the underlying variations in those things that make up our estimates of K? So, for example, we know that variations exist by geographic location, and we also know that they vary by clinical area. So, for example, in geographic locations, we know that there may be differences in the cost conditions of delivering healthcare. There may be differences in the technical efficiency in delivering healthcare across geographic regions. We also know that there are really important differences in the relationship between healthcare spending and the marginal production of QALYs by different clinical areas, or in the UK, you might call them program budgets. And there might also be different preferences which are relevant here as well. And so our estimates of K are sort of predicated on what's happening at an average level in a whole healthcare system. So I think there's sort of some underlying questions there about what we should make of the variations that sit underneath those national level estimates. And I was also intrigued by an aspect of Shankar's presentation around the differences in willingness to pay by particular subgroups. And I think the subgroups that were raised for discussion in Shankar's presentation were income groups and disease areas. And I think that does also raise some really interesting questions about variations in thresholds by subgroups. And it gave me cause to reflect on some work we've been doing in our a research program in Australia we've been working on in recent years called QACA, where we've been looking at willingness to pay of society for QALY gains by age. And we found some fascinating results there. On average, it appears that there is a small marginal willingness of society to pay more or to put more priority on health gains in children compared to adults. But interestingly, that doesn't apply to under 4-year-olds, and that appears to be quite a robust finding, whether the QALY gains come from increases in survival or changes in quality of life from a whole range of different aspects of quality of life. Now, I raise that because when I'm thinking about differences in a willingness to pay threshold by subgroups, the question that I'm got in the back of my mind is, who should define what the relevant subgroups are? So I'm just going to leave that question hanging, and maybe we can come back to it. And then my third bullet point here, oops, sorry, if we could just go back to that previous slide, thank you, is what if the healthcare system isn't a quality maximizer? Because if we're estimating a threshold based upon qualities, we are sort of linking spending to the generation of qualities. But what if the healthcare system isn't a quality maximizer? Should its HTA body assume that it is? The messy reality of healthcare systems, and some of the work that we've done in Scotland and Wales, trying to identify specific opportunity costs arising from new technologies having been recommended, looking at the way that budgets are prioritised there, is that local healthcare bodies have multiple goals. For example, they're not just trying to estimate trying to maximise quality, they're trying to meet waiting times targets, they're trying to ensure that they don't overrun on budgets. They're trying to balance up a whole bunch of different imperatives and goals which they're given by the Department of Health simultaneously. So some of it's about process, some of it's about outcomes. And in general, I think what we see healthcare bodies doing in the NHS is kind of might be characterised as sort of satisficing behaviour. They're trying to achieve one goal and then move on to the next. And it's certainly a long way from quality maximisation. So it sort of raises the question of what else matters and by how much. And one of the things that I've sort of noticed over the years in working with a range of HTA bodies is that there's a bit of a reluctance or a bit of a resistance to being very explicit about what these other factors are and exactly what trade-offs between them we should be making. There was a nice methods review, I think it was back in 2012, that formally assessed the potential use of structured decision-making or multi-criteria decision analysis to try and understand the extent to which these other factors matter and what societal weight should be placed on them in decision-making alongside cost effectiveness. And ultimately that was rejected as an approach. And I think on the grounds that the NICE Technology Appraisal Committee preferred to retain the ability to make a case-by-case decisions. But that makes it really hard to get an understanding of how decision-making committees are assessing benefits gained and weighing that up against benefits foregone. So I think we've made a really good start. Next slide, and then I'll wrap it up, Jessica.
Okay, thank you.
Next slide. Great. And I'll just go through this super quickly, but just basically, who should set the threshold is another thing. As health economists, I think we're now producing incredibly valuable evidence on both the value of K and of V, but that doesn't answer the question of who should set the threshold. And there's different views on this, so I'll just flag this up really quickly, which is to say, is it a matter for us as researchers to say what the threshold should be? I mean, we can provide evidence, but we can't dictate that. Should it be the HTA bodies? Some would argue that that would not be appropriate and that it should really be the role of Parliament, or it's been even suggested that it should be something like a threshold committee, which is independent of both Parliament and independent of HTA bodies. There's a bunch of different views on that which might be taken, but it is an important question because it does have relevance to how we might ever reconcile the differences between estimates of K and V. I can leave it there, Jessica, and then hand back over to you.
Oh, fantastic. Thank you. You've raised some really good questions. And a lot of this, like you said, overlaps a bit with what's been brought up in the audience question. So before we get into the Q&A, I just want to say a major thank you to Dr. Laura, Dr. Shankar, Dr. Wanrudee, and to you, Dr. Nancy, for these enlightening presentations and for your valuable insights and reflections. So we have overrun slightly, so we're going to do 10 minutes for Q&A, then I'm going to wrap up with closing remarks, and perhaps after that, for people who can stay on, we might stay on for another 10 minutes if that's okay. So I'm going to kick off the Q&A with 2 questions that came up from the audience that are related. So One was directed at Dr. Shankar's presentation and asked whether estimating a cost-effectiveness threshold using demand side could be erroneous because people may claim that they will pay more than what they can actually pay in reality. So what do you think about this, and how do we deal with this? I think this is a question actually for all of our speakers, because we all have thoughts and opinions on this. And then someone else asked a practical application question that was quite related to that, which was, is there a conflict if the demand side threshold was developed based on societal value, but the cost effectiveness analysis was conducted using a health system perspective? And then the same but flipped, if the supply side threshold was developed based on a health system perspective, but a cost effectiveness analysis was conducted using a societal perspective. And so I would ask the speakers please to jump in and elaborate on all of these points. Shall we start with Dr. Shankar? Sorry to put you on the spot, but since the first question was directed at you, perhaps you can have a stab at that one.
Yeah, no, I think that both the questions may not have a very straightforward answer to begin with. So I completely agree that there's always going to be a conflict between a stated willingness to pay and an observed willingness to pay. And that is a question that still would remain relatively unsettled. I don't see that there is any specific way in which we can reconcile this issue. The only thing is that there is a certain trend in which there's a certain trend that you can definitely still observe within your data, looking at the subgroups and looking at the stratified analysis, etc. And it gives you a broad sense of direction. And it also, in a way, gives you a sense of, so while doing these analysis, we also incorporated questions wherein, which is also related to the second part of the question that that has been asked in the chat box. So where we ask that the individual to report as per from a self perspective, a household's perspective, and a community's or a societal's perspective. So which means that if it was to be paid for somebody else, then what should be the willingness to pay, etc. So, you know, when you play around with these questions, there's a way based on which you can potentially identify the extent to which at least there's been an overstating of the willingness to pay by individuals, which is not really reflective of their actual ability to pay. So while I do agree that there is a certain degree of limitation based on the method, however, if these questions are also maybe positioned in this particular manner, then the extent to which people have tried to overstate that can potentially be examined.
Thank you very much. Does anyone else have anything to add to that, or shall we move on to the next question?
I can add, because when we have done willingness to pay study, what we have done, which may sound very silly, but is simply to add a sentence telling respondents that this is what normally happens, that we all usually observe that individuals state a willingness to pay which is much higher than what they will normally pay, but we ask them not to, and we ask them to please take into account their budget when they on their household income and the implications of what their answer will be to this household income and to their household budget. And in that way, I mean, I know it's just only asking respondents, so you cannot force them really, but just having this sentence right before they have to answer, I think is very helpful. And it allows them to, well, actually consider that, you know, this has to be in my mind when I respond to the question. And what we found was that there was a very strong relationship between household, because we also asked them about their household income. So we found a very strong relationship between the household income and the willingness to pay responses. So this sort of indicates that it's in the right direction. And I'm happy to take the later, I don't know, now or later, the other one about the conflict between using a healthcare perspective and willingness to pay threshold, if that's okay. Or Nancy, do you want to comment on, or anyone else, sorry, on...
You go, Lara.
Okay, because I thought that was a very good question. The question about whether there is a conflict when we used a supply side threshold, but we applied the societal perspective, or when we used a demand side threshold, but and then we applied a healthcare system perspective. I think that's this has been already pointed out. So if you are using healthcare system perspective, your aim is to maximize health, and you live in a country or in a system with a fixed budget, the most appropriate threshold is the supply side threshold. And if you're using a willingness to pay study threshold or a demand side threshold, is not the most appropriate piece of information for these decisions. And the other way around, if you live in a system where you want to maximize welfare, where you want to take into account broader impacts to the societal, so you use a societal perspective in the analysis, and you also have some flexibility in the budget, then the demand side threshold is the most appropriate one to use. And then there is this trying to reconcile both perspective, which is and you be somewhere in between. You may have a fixed budget, but you may want to take into account broader impacts, so take into account a societal perspective. So which threshold do you use? Do you use K or do you use V? Well, the answer is that you need both. So you need K to measure the net health gains in the dimensions that you are measuring, but then you need V in order to provide or attach a monetary value to all these dimensions that then can be translated on the same metric and compared with the societal cost. Sorry.
Brilliant, thank you. I think I saw Dr. Shankar's hand up as well, so might want to come back on that.
Yeah, no, just wanted to add to what Laura has also mentioned, that in the design of these willingness to pay surveys, the point at which you start with your bidding game, it also has a certain degree of understanding about how much do interventions for those kinds of disease conditions typically cost. So it doesn't really push the respondents to just fish around at certain levels of cost, which are completely unrealistic. Yeah, thanks.
Thank you. Okay, a few people have asked questions about, and Dr. Nancy also mentioned this in her discussion, about changing the threshold. So someone asked specifically whether inflation was taken into consideration during the analysis that Dr. Wanrudee presented. And I think this relates to a broader question that a lot of people have about when should we be changing the threshold? And someone else also asked whether if a new supply side estimate was estimated, should that become the new threshold? So any thoughts on this from the panel?
If I could just say, just begin by making one remark on that, which is we obviously want the threshold to be as accurate as possible. And clearly, if you have the same threshold for 10 or 20 years, given all the underlying changes in the healthcare system efficiency budgets and so on, it's clearly either wrong at the beginning or wrong at the start. It can't exist and be accurate over that period of time. So we do need to change the threshold, and we need to be willing to do that. But the only thing I would just give as a qualifier on that is I think it's quite difficult for HTA bodies to change the threshold. And I think we need to acknowledge that there's a sort of practical difficulty here. So, for example, if you have an HTA body that makes a decision about a new technology under the circumstances of one explicitly stated threshold, and then in the next period that threshold changes, there would always be the potential for organisations to appeal previous decisions. And so you might end up in a position where you're just constantly in a round of appeals, and you find it difficult to say no to things if the threshold is increasing. So I do think there are some sort of practical and sort of almost political is probably not quite the right word I'm after here, but some administrative challenges. There are some costs to the organisation of implementing a new threshold that we need to be aware of.
Hi, can I jump in? Yes, not physically but virtually, but so on the topic of inflation. So I also share the answer by typing as well to some of the question, but we did not take into account inflation because the decision was made at that corresponding year. So that's why we thought when we look at the impact on cost, we should keep the year to be to keep the cost unit to be the same as the corresponding year when the decision happened. But I also may perhaps I can add to Nancy's point that it's never an easy question, right? Like, you know, so, and there's certainly practicality, politics side, so many other factors to take into account. And I know I'm very proud health economist, but at the end of the day, I do believe that economic evidence, as Dr. Shankar highlight, is one criteria. You know, as we talk more about rare disease, high cost intervention, there's so many other factors that the model are not meant to be a magic bullet to answer it all. But it also doesn't mean that it cannot help. So just we often hear these two with rare disease, and just can you mention, I think there's some question along rare disease as well. Like, you know, that you know, it's not going to be cost effective anyway. So why bother looking at this? Well, actually, if we were to do economic evaluation, you know, I think it can help us conduct scenario analysis. It can help if we want to explore doing managed entry agreement, not to support that we should do one, but if we were, like, you know, just in the negotiation process, you know, having a model, I think it can certainly help, regardless of whether it will be cost effective or not. But certainly there are many other factors to consider as well. Thank you.
Indeed. Okay, so we are almost out of time. So I'm going to close the Q&A. It feels very early because there's so many questions, and perhaps we can stay on after this and address some more of them. But I just want to say another thank you to the presenters and our discussant again for the presentations, and to thank all of our participants for your engagement and your excellent questions. We have, so this is part of a 4-part series. There are 3 more webinars to come. And before everyone leaves, I want to make sure that you have the opportunity to vote on what topic you would like to hear about next. So there have been a few questions, for example, around how opportunity cost was calculated, or how a cost effectiveness threshold is estimated. And that is something that Dr. Laura unfortunately didn't get to finish talking about in her presentation. So if you could take a moment, please, to vote on these potential topics for the next webinar. To give a bit of background on the incentives for innovation idea. So a few of our speakers today talked about pricing and specifically how manufacturers might price up to a threshold. So that topic would address questions like whether the prices that manufacturers do get in LMICs for new high-cost pharmaceuticals are enough to incentivize the innovation of new drugs that will generate health in the future. Bearing in mind, of course, that higher prices paid now also mean that there's less overall health for the healthcare system, as there's less money available now to fund other life-saving or life-improving healthcare. Other topics included informing health benefits package design and incorporating equity concerns in HTA and/or health benefits packages. So someone had also asked about distributional cost effectiveness analysis and the appropriate cost effectiveness threshold to use when you're doing a distributional cost effectiveness analysis. So thank you to everyone who has participated in the poll. Still going a bit, but it looks like everyone's pretty much participated. So we can end the poll now, and we'll take that into account for our next webinars. Thank you, fantastic. And then I'm not sure, speakers, if you have an extra 5 minutes to stay on. I'm sure you probably all have other plans for the day as well. If there are any other burning questions that we want to get answered while we're all online, there were a few good things to come up. So if there's, I suppose you've all looked at the Q&A. So if there's anything that you saw that you really wanted to answer, now is your chance to do that. Okay, and there's one that's a burning question for me that came up during Dr. Lauer's presentation. So someone asked whether there is empirical evidence showing that cost effectiveness analysis improves health system efficiency, either at the country or a lower level. And I think we could expand this to ask whether the use of an explicit threshold improves efficiency. And after this question, then I think we will sign off and call it a day.
Well, to be honest, I will say that I am not really aware of empirical papers that have looked at the impact of cost effectiveness thresholds or cost effectiveness analysis on efficiency per se. So Nancy was showing before some papers that have looked at the impact on decisions, so which decisions were made. But to be honest, because if I think about what type of study that will need to be conducted to measure the impact of the use of the threshold or the use of cost effectiveness evidence overall on efficiency, I can see how it's so difficult to measure because efficiency is affected by so many other factors. And to be able to assign the role of cost effectiveness evidence or cost effectiveness threshold to that, I can see how this is really, well, it will be very hard. I don't know if any other speakers is aware of a study that have tried to do so.
Dr. Nancy, did you have something to add?
Yeah, I mean, it's such an interesting question, and I noticed that in the questions box as well. I mean, what you could do would be to look around the world at all of the technologies that have been rejected by HTA bodies on the grounds of their cost per quality being much, much higher than a threshold. And then you could estimate what the budget impact of those would have been if they'd been approved. And using the estimates of K that we have, estimate how many QALYs would have been lost had those decisions been implemented, because K tells us, you know, how many QALYs would have been lost elsewhere in the healthcare system. So we could actually figure out what inefficiencies have been avoided by the use of decisions. It'd be a little bit of a rough and ready estimate, but we could do it. But it also sort of got me thinking about another issue, which is I think in general, health technology appraisal has given us a lot of very good evidence on the costs and benefits of new technologies. But I still feel that the vast majority of what we spend money on in our healthcare systems remains unexplored in terms of costs and benefits and really good exploration of cost effectiveness. So that would be my, one thing on my wish list of things would be for us to spend as much time looking at the cost effectiveness of old technologies as we do looking at new technologies. Just a general comment.
Fantastic. Dr. Shankar, did you want to weigh in?
Yeah, just a small addition to what Dr. Nancy has already said. I think a lot of assessments have been done to try and demonstrate the return on investment more from the budget savings point of view, to say that with decisions that have been undertaken using HTA in public financing, how much have they led to savings in terms of cost? That's been one definite yes, and there are certain examples. We've done that in Indian context also. There are lesser that try and say that what have been the QALY gains, but there are some assessments that have been done to say that how much was the access to treatment improved with those decisions that led to incorporation of interventions that were there. But I think that another interesting approach could be that as you try and periodically look at your supply side threshold, the assessment of the changes in the health opportunity cost as you move and continue to incorporate more interventions into the health benefit package, that could give another sense of indication. Although it may pose more challenges to answer the question that is being posed, because eventually your threshold may continue to also increase as you continue to keep on increasing interventions within your health benefit package. So I think it's a very interesting question and leaves a lot of room for further research.
Indeed. Okay, Dr. Wanrudee.
Hi, thank you. Building on from the question a little bit, I guess if I can expand beyond just cost effectiveness analysis, because I think with our country partners who are trying to institutionalize HTA, or even in Thailand, we often have to make case for why we should do HTA. And yes, a cost effectiveness analysis is a big part of this. So there actually a work that we collaborate with University of Strathclyde. So what we did was we use simulation model. So we have a list of intervention, and I put the link to everyone so you can go see the policy brief. There are also relevant publication from that too. So we look at a list of intervention, okay? And we make an assumption that scenario 1, policymaker will just fund things, invest in things on first come, first serve, without comparing cost, looking at either comparing costs or anything at all. And then on another case is when we look at all the intervention and we use ICER, look at the cost effectiveness analysis result, and then we invest accordingly. So when we show those simulation, it does show that, having a HTA study conducted or doing an HTA study does try to increase, you could say, the benefit gain, and with a lower amount of cost than just randomly or first, investing thing in first come, first serve. But that was more in the larger sense, not just like cost effectiveness analysis, but it's just one step toward trying to make a case that, I think HTA can be a tool to support or inform policy making. Thank you.
Okay, thank you. I think we may have just given someone a PhD topic idea. So yeah, there's so much more that we could discuss on this topic, but we do need to wrap it up now. So I want to just say another thank you to all of our presenters and to our discussant. This has been really incredible. It's just been absolutely wonderful to have all of you in the same room, so to speak, talking about this. I've really enjoyed it, and I would love to keep talking. But yeah, so we do have to wrap it up now. So thank you, everyone, and thanks to all of our participants. I hope to see you at our next webinar on February 27th. Thank you, and goodbye.
Thank you very much.
Jessica.
Bye-bye.
Thank you. Bye.
Thank you.